Um, I'll be doing a segment here on data access management. Together with me, I have Akuba from the Norwegian Institute of Public Health. She's joining us from Ghana, and she's going to join towards the end of the presentation. Unless there was some problems with the power today, but we hope she'll be with us. Yes, so welcome. My name is Markus Bekken. I'm with the University of Oslo, leading the tracker development there. Before diving into the topic, for anyone who noticed, there is a Menti code at the top of the screen. For those that are with their devices, they can go to Menti and enter this code and answer a question there. I'll take the code back later in case you didn't have time to or lose the code now, or in case someone comes late. We'll also take this code and ask the question on a later slide. Yes, so what is data access management? Well, what I'm going to focus on today is mostly this. We're going to have our users on the side here, and we have our data. We need to split, we need to decide what data which users have access to, and we need to organize this in the most efficient and most sensible way. In this case, we see that we have some dashboards at the top here with some aggregate numbers, and then we see a screenshot from the tracker at the bottom. The data is the same, you can say. In the dashboard above, you see some data from the COVID program, and at the bottom, you see the tracker with the same COVID data. Still, this might be an area where different users will have different levels to these two pieces of data, and this is what we're going to dig into today. What is the difference between data in the tracker and the aggregate values? On the last slide, I had kind of hinted at the difference. There would be some users accessing only the aggregate and some accessing the tracker. And I would say that the main difference is that the tracker data is almost always personally identifiable, and therefore more sensitive. There is a high level of utility in getting access to this data, but probably not all your users would need this access. Having individual data access probably means that the user actually works with that individual. If you have set up your data access in the best and most restrictive way. So to dig a little bit more into this this concept right now, I tried to make this figure that shows the convenience on the x-axis here, and more convenient is further to the right, and access restriction on the y-axis. So more restriction is further up on this axis. And if we imagine a super user, they would be somewhere over here. They would have very little restriction, so that's why the y-axis is so low, and they are so far to the right because this is super convenient. When you're developing in the development environment, or when you're when you have a user that needs a lot of access, then they would be somewhere over there. there is always a struggle between convenience and access restriction, and it will be our job as tracker instance managers to make sure that our clinic users and our actual users have as much restriction as possible without this being a problem in their day-to-day work. So this is what we're going to touch on today, and this is a topic where there is rarely a very clear answer that I could give you. I will talk a little bit about the tools that we have at our disposal. I will talk a little bit about the concerns you need to think about. And Akuba will, in her session later, give some examples from the field on this access restriction and access planning in practice. The next figure here is something I hope looks familiar. It's a risk assessment matrix. This is a very, very simple one with just 3 categories. Any risk would be classified as green, yellow, or red in this simple model based on how probable they are. How probable is it that this is going to happen, and also how high an impact it would have if the risk becomes a reality. When we work with data access management, and we look at the risks in this field, the impact is almost always regarded as high. If you lose data, or if data is tampered with for an individual, then you would be in the right column where the impact is high. So our main job here in this session, and also your job when you go back, is to make sure that you try to manage the probability of this happening. And this is what this session is focusing about. It's focusing on the probability and trying to minimize the probability. Even if a risk has a high impact, it might be considered green if the probability is low. So I'm going back to this Menti, and I hope that you might already have answered it, some of you. Those who haven't, please make sure to enter this code and answer the question. I will stop sharing the presentation for a while and show the Menti answers.
Marcus, can you put the code into the chat? I wasn't fast enough.
It's yeah, it's coming back on the screen in a second. Let me see. And then...
So Marcus, what you're telling us is not everybody should be a super user.
Yes, not everybody should be a super user, exactly.
Only a select few.
We should think about who has access to our data, and we are getting in some answers to the questionnaire. Did you work on a project that got bad publicity? This is a very open question at the moment. A lot of you have never done that. That is a good. That is very good. Congratulations to those who never got bad publicity on their project. And thanks for answering. If you got bad publicity, this is probably not a good memory.
They
we
will
have
not
one.
make the same mistake twice, I'm sure.
Yeah. About a third of the ones who have answered so far did experience bad publicity. And right now, I'm gonna bring a case that I myself had the pleasure of experiencing. To the others, please also share yours in the chat if you have any similar examples that you could give and share with the other participants. You can do that in an anonymous way, of course. I will stop this and go back to my presentation for a while. All right.
What was your project, just so I can keep an ear out for it?
Yeah, mine, we got 5 in local media. Bad publicity in my local media here. Thanks.
In Norway.
And then I can present again. Yeah, so this is my bad story, and I'm gonna share my screen again. There. I trust you can see a guy holding a piece of paper. In 2012, I was working for one of the biggest Norwegian government sites that gave citizens access to their tax returns to deliver and see their tax return data. And one day there was a fault in the system, and hundreds of thousands of people were logging in at the same time, and tens of thousands of these people were logged in, and they saw the data of this one person, and they did not see their own data. They saw the data from another user. His name was Kenneth. I never forget his name. The picture here is of the minister that was in charge of this solution, and he had no intention of supporting us. He went directly into the media and put a report on the table that said that this solution was not good enough and that it had cost 1 billion kroner. And we all felt pretty abandoned there for a while. In the ensuing days, it became clear that we had done our jobs. We had done our risk assessments. We had all the NDAs in place. There was no criticism directed to us. We found an error in the hardware component, and we kept our jobs, and everything went back to normal, thanks to us having done a good job up front. But of course, the incident never blew over. We still hear about this. It's been almost 10 years, and this is what people remember still when they're thinking about this government portal. So back then we learned that you need to do your job. You need to note down all your decisions, and you need to do your risk assessments. This will minimize the risk as much as possible. And if something goes wrong, then at least it's important to be able to document that what we have done and try to find out what went wrong. So as I mentioned, if you have any stories, please share them in the questions channel. We will do a break and look at them if we get any other stories about incidents that comes from any of you. For now, we will go back to the house for a while, and we will go through the different rooms where the data access management is a concern. And we will start with one that is very easy to forget. The infrastructure. Who has access to the server? And especially the database server. If you have either physical or terminal access to this place, then you in essence have all the data as well. And you have to make sure you have an NDA with everyone that has access. And this is not only the company that does hosting for you or the team members that has access to the server. It's also if you give access to Bob, for example, or to me, you should have an NDA, and there should be a roll-off routine, both for staff and for these super users that might log in and help with something. Please don't forget this. This is the first point because it's so easy to forget when you talk about data access. This is also going to be the topic of the hosting and security sessions, and there's a reason why it's mentioned in many places. The other thing you have to take into consideration when you're building your data access design is the legislation and policies. And I do have a Menti for you guys. That's on the next slide. And before we go to that, the questions you should ask yourselves is which legislations and policies are relevant for you, and which ones do exist. Sometimes they might be a little bit hard to find, but this is a job you have to take. You have to find the legislation for storing personal information, personally identifiable information, and for how it can be treated, how long it can be stored, and so forth. One particularly hard question that has to be asked and is hard to answer, and it should be hard to answer, is how can you share this data between clinics in a longitudinal setting? If you start your treatment in one clinic and go somewhere else, is it okay that they see the data? And this is sometimes a very new question because there was never a information system capable of doing this before, and you have to find you might have to dig into legislation that was not really meant for this kind of situation, or you might even have to look for a change to legislation for your system. In Norway, this is the case like nowhere else. We have been working with Tracker in Norway lately for COVID surveillance, and this question is super hard. The traditional answer is that you cannot share anything between two clinics, end of story. We did find some loopholes, and we were able to make sure that we, with the lawfulness in hand, were able to share data, but that was not easy. Next question: which standards can you follow or look to? And this is in Europe. We are always using the oh Lord, I forgot the abbreviation. Someone can put it in the chat, I'm sure. Oh Lord, I didn't put it here, and I didn't put it in my notes. I'll come back with the abbreviation in a second. There's the HEPA HL7 standard that you can look at, and there might be other standards as well that you should look into. Okay, and GDPR was the one I was looking for. GDPR is the European Union standard for storing identifiable information, and we find it a very practical checklist that that anyone could and should look through in terms of designing data access. The GDPR would touch on things that would be system design, but also things that would be service operating procedures and the rights of the people that has their data stored in the system. And what do we do when the policies are missing? I think that the general recommendation we have there is that if there is no equivalent of GDPR that is valid in your area, you might still look at GDPR and make sure that you follow that. Or follow a good practice or standard that is used somewhere else. That might be the best recommendation. So there is one more Menti in this session, and this is starting now. We're going to look at some concerns, and I'm going to talk about 11 concerns. What I want you to do while this is going on is to go into the Menti and rank these concerns from top to bottom, which ones you already have given space in your project or project plan or plans so far. So please open the Menti and we will have a look at it together after this these concerns have been gone through. The first concern is simply lawfulness. In lawfulness, based on which laws you're following, this is impacting a lot of areas. But as a concern itself, you have to make sure that your data access is lawful and following the legislation that is in place. This might be touching on consent. It might be touching on what is necessary to perform the job for a clinician. It might touch on human rights, expression of freedom, and it is a concern that you are following the law. The next topic is the purpose limitation. The purpose limitation is simply put that you shouldn't give people access to data that they do not need, explicitly need. If they do not need it for the job, they should probably not have access to the data in the first place. And this is part of designing access to your data. The next one is data minimalization, and that's relevant in many ways, but one of them is for data access management purposes. You should not store more data than you need. There should be a reason for why you store each piece of information. There should be a processing or a process that needs data before you accept a new data element that is part of a personally identifiable piece of data. Accuracy is the next one, and this is a point that presses that we should have. If we have data, they should be accurate and up to date. If they become incorrect or out of date, they should be rectified or deleted. And if they're not, they will contain potentially false information as time passes. The next one is storage limitation, and this is that the software must ensure that it's not possible to identify the data subject or longer than you need it. And this is something that is very common to have in legislations, that after a while you have to delete the data. It should not live forever. And also this is a part where we don't really have good system support in DHIS. This is usually something that you would have to delete with a script or similar. And then we have another non-system point here, consent. This is a very important point for GDPR and HEPA HL7. The consent has to be explicit. You have to consent that data is stored about you. Unless there is an exception, like for contact tracing in Norway, there's a different set of rules. So you cannot, you don't need consent for to store anyone's data about COVID. But in almost all other cases, you need consent. The consent should be voluntary, and it should be as easy to withdraw the consent as it was to give it. The next concern is confidentiality, and this means that personal data must be secured against unauthorized disclosure or access, and this is maybe one of the main points that comes to our minds when we talk about data access management and what we have been thinking about and talking about so far in this presentation. Much of it is in confidentiality. You should not give access to data that well, you should protect the data so that it's not accessible by unauthorized parties. The next one is integrity. This is about not making sure that personal data is secured against accidental or unlawful destruction, loss, or alteration. So if it's very easy to go and change something in the system without anyone noticing, this might be a loss of integrity. Next one is accessibility. The software that is processing the software data must be available to authorized personnel who require it for their work. This is also a point that comes to mind when we talk about the data access, and this is maybe one of the main points that people think of. Then we have resilience, which means that the data is protected against vulnerabilities, attacks, accidents, both physical and digital, that they are not lost. If they are important for people's health, it's very important that they are not lost. The last one is traceability. Traceability is documentation of the changes that is made within the software to personal data. If you change something, then it needs to be traceable what has changed, and this also feeds back to integrity. So now we have gone through these principles and concerns, and you have hopefully also ranked the concerns on your Menti. So we will have a quick look at the other ranking here, and I'll stop share and share my screen. And now I think you can see the ranking that was given by the audience. Confidentiality seems to be the one that is ranked at the very top, and this is something that you are thinking about already, which is very good. It has a kinship with the very lowest ranked point here, purpose limitation, because you thanks, there are some more votes, and the purpose limitation went up a little bit. Purpose limitation is about trying to make sure that the ones that do have access only have access to what they need, and that we make sure that data is not unnecessary data is not shown. I'm glad to see storage limitations so high up, and this this might mean that you are actually planning and building scripts that will delete data when it gets old, or that it at least is a plan to delete data when it's no longer needed. Resilience is ranked at the bottom there, and maybe this is sometimes because resilience is something that we mostly think about in terms of the server, in terms of hosting, and not so much in terms of the data access in a way. Thanks for your responses. Data minimalization at the place 10 there, I was gonna say that it has there's another reason for minimizing the data, as well as the fact that collecting something you don't need is a risk. Minimizing the data is also good for the people collecting the data. So I would have loved to advise you to think more about this data minimalization in your projects. Lawfulness is pretty low. Is that because there is not so many laws or legislations that you are subject of in the settings you're working? We have 14 responses, so I think I will leave this slide now. Thanks everyone for sharing. We will do a screenshot of it once it's you can still give your answer even if I stop sharing, but and we'll put this into the presentation. So when you download the presentation, this will be, the responses will be there. All right, so now I trust we are back in the presentation. If we continue to the other rooms of the house and have a look at the training and IT support unit. The data access concern is very prominent in these rooms, and what we have to think about is whether we are training the users to behave ethically and to behave smartly. Many of the attacks, when you want to have access to the system, goes through the users sometimes has an aspect of social engineering, and we have to make sure we train the user not to give that password to other people, even if they're calling and telling the person that they are calling from IT support and need their password. Something that has been useful is that when we have Android devices, then some people are saying that they're telling their users that they should think about the device like their patient register. Like, this is your patient register, this device is your patient register. Please make sure you lock it and keep it as secure as you do with your old paper register. And then one point at the end there, make sure to clean the inactive users and restrict physical access to devices if they have them. And then when it comes to Android, one important part of data access might be MDM and the ability to remote wipe if a device is lost, for example. And have password enforcement on the Android devices might also be an important step to make sure that the data access is as limited as it can be. and sometimes people are sharing devices between themselves, and you should know and look into how this is done, and make sure that if it happens, and it happens in a way that that was planned, and that you that was part of your understanding when you designed access to the program, for example. So the next room we're going to get into a little bit is the design and configuration process, and I'm not going to go too deep here because this is what Akuba will do in a little while. She will look at one practical example of design and configuration from an e-registry setup in Bangladesh. I will touch on some of the principles now, and then she will have time to dig into it a little bit more. Data access management is part of a configuration, and I see that from the chat here, Abdul, you're mentioning the same. Data access management is something that is part of your program configuration, your user groups, and it might also integrate with the decision on what to put in which program stage, and how to divide your programs on very practical things like this. And therefore you need to think about it in the beginning. You can't do it after you have put the data and after you have put your system into production. You have to have a plan for your different users and what they should have access to from the beginning, and this has to be part of the design. Just to bring this figures back briefly, when you make the design, you need to think about the user's functional needs. You need to be on the left there and think about what do they actually need and what can we restrict. Also you have to think about the risks and whether these risks are acceptable. Maybe you have to share devices. There is no other way. And this means that everyone in the clinic needs to have the same access, or will in practice have the same access. And this might be an acceptable risk, but you should know and talk about this risk and write it down in your risk assessment. You should, of course, also make sure when you design that you stay within legislation and policies. In the very beginning, one of the things you have to make sure to design is what are the different roles and what's their jobs. The data entry clerk, for example, might be entering data on local cases, and that's everything. He should enter data in his clinic, and that's all. A receptionist might be doing some registration work, but not add data to the patient record when it comes to medical conditions, for example. There might be clinic workers that needs access to the record for treatment, but does not have any right access. And these are roles that is just added for your own thinking and your own design. So Akuba will get into this as well. A lab worker is an example where we many times have seen that a lab worker needs access to the lab stage, and he might need that access for a huge geographical area, but he does not need access to the clinical details for the patients. And this is things you can and should design into your program from the beginning. And then a little bit more on a question we have seen before, before handing it over to Akuba. What is the need to see access across your organization units, across clinics? And what's the options in legislation, and what can you do? Should some of your users have access to search for the whole organization units, or just some? The lab users, for example, usually would be able to search and find data in all org units, whereas a clinic user sometimes should not. So what happens when you search and find data outside your organite? Then we have some options, and these are fundamental decisions you need to make and also explore. One of them is that if you find someone, if you search and find someone in another organite like this, if you search for deer and you find that in Deir el-Bala, there is a woman called Deir el-Bala woman, and this is the woman that you were supposed to work with. She walked into your clinic in Al Zawida. Then one option is to pick up the phone and call them and ask, can you please transfer this woman to us? We don't have any access. And this would be what we call the closed access. Another option would be that we allow the breaking the glass functionality. This is what happens if you put your program into protected access. Then if you allow breaking the glass, then you would see a screen like this. You would have to enter a reason for why you want to access the record, since it belongs to another clinic, and this will go into a audit table. But it allows a need-based access to other clinics' data. A third option is that you would be able to click on any of these and directly open them and work with them directly. This might be fine in some settings. If you combine it with a good routine for going through your audit logs and analyzing the audit logs, it might be secure enough. And then one very important question is which stages do your users need access to, if they need the entire program or only some stages. And this is the topic that Akuba will dive more into when she's ready to take over. What stages and what roles do you have, and who needs access where? And with that, I will hand it over to Akuba here. If you are ready to unmute and take over.
Okay. Hello?
Hey, Akuba.
Can you hear me?
We can hear you.
Okay, good. Hello, everyone. Let me find my screen to share.
While Akuba's finding her screen, I just want to say, Marcus, I really like the breaking the glass feature because I think most people want to do the right thing. And that breaking the glass just gives kind of an extra nudge saying, are you sure you should be doing this? I gave the example of in the document or in this chat of working in a hospital, and a high profile patient came in, and there was a lot of news stories about this patient, and everybody wanted to know what was going on. And well, a lot of healthcare providers, of course, they had access because they were just in the system. And so they looked at the chart, this patient's chart, and then after doing some log audits, they looked at all the people that had not had any responsibilities for this patient, and they ended up firing anybody who did not have responsibility due to confidentiality issues. So I think people want to do good, but curiosity killed the cat. And I think this is a good highlight of how to encourage people to know when they're going beyond what they should be. I mean, this could also be for if you have a neighbor that comes into the clinic or an HIV patient. There's lots of things that it's good to have this breaking the glass and considerations for access. And with that, I'll turn over to Akuba.
Thank you, Kim. So my name is Akuba Dolphine, and I'm a senior implementation advisor with the Norwegian Institute of Public Health in Oslo, but I am currently in Ghana visiting family, and I'm hoping that we have a stable internet connection. So I'm going to be talking about designing for user access, and I'm going to use a quite complicated example from an e-registry project that we did in Bangladesh that's actually just wrapping up right now. So it was a research study that was a customized randomized control trial called Strengthening RMNCH Services with an Electronic Health Registry. And for those who were at my session on Friday, we mentioned that an e-registry is one of the most complex style of a tracker. And this one in particular had clinical decision support. We used it also to identify at-risk patients for referral. So this was done at point of care so that the health worker would get this information. We had client communication where we sent SMS reminders to clients for their very specific ANC appointments at a very specific clinic. And we also sent even more targeted SMS messages to patients who had been identified to be at risk. And then, so somebody had come in and we identified that she had developed gestational hypertension, for example, we would then send them a message and say, hey, your next appointment is such and such a date. You've been at this appointment, we will check your blood pressure and we will make sure that your child is okay, because of this, that. We also provided feedback dashboards to health workers where it helped them track their progress towards specific targets. For example, some people had a target of having to register a certain number of pregnant women, or making sure that they always screened for, diabetes or blood pressure, or always take the temperature when somebody showed up. And so every health worker, depending on what their targets were, would be given a dashboard that was showing their progress. And if they were not making progress, we would give specific action items to tell them, hey, this is what you have to do to make sure you reach your target, so that it's not a surprise at the end of the month when you have not reached your target. So you're going to have to bear with me a little because this is a very, very complicated system. And we kind of chose to use this use case to show you the capability of DHIS2, that it was able to deal with this very complicated system in Bangladesh. But then, of course, I have to explain it to you, so it's going to be a bit complicated. So the Bangladesh public health system has two directorates. One is for health services, which includes, anything that's wrong with you. You have a temperature, you have a fever, you are pregnant, anything at all that's wrong with you, you can go to the health services. Then there's also a directorate for family planning, which was created before, I believe, the Directorate for Health Services, and they were focused on, family planning during that time. Quite a few decades ago, when family planning in developing countries was a big deal, and a lot of countries invested in that. And this actually, I believe, began in, in that part of the world, in Bangladesh. So for each branch, they have two types of health workers. They have those who work in the community and those who work in the facility. So the community health workers can go door to door to people's homes, or they can also have kind of like outreach satellite clinics where they stay in one particular place, or, they go to one particular place and then they call the community members to come and meet there, and, they will give them the health services that they need. So for the health services directorate, their community health worker is called a health assistant. And this health assistant is responsible for pregnancy registration and vaccination. They also have a facility person called a CHCP. The facility person for family planning is a family welfare visitor, and the community worker for family planning is called a family welfare assistant. Now, if this list of services shows that everybody is responsible for pregnancy registration, because the country wants to make sure that every opportunity to find a pregnant person and, register her so that they're able to follow up so that she gets antenatal care, she gets care during delivery. And of course, if you know that a woman is pregnant, then when the child is born, you are aware that there's a child that's, that's coming or a child that is born. So then across all these different cadres of health workers, everybody is responsible for pregnancy registration. Then the health assistants are responsible for vaccination. Actually, that's the primary purpose, one of the primary purposes of the Health Services Directorate. So they do, the regular childhood vaccinations, but they also do tetanus vaccinations, which in that part of the world is really focused on adolescent girls because it is a key protection that you have to have when you are pregnant. So they actually have a huge drive to vaccinate adolescent girls with tetanus so that by the time they are of age to, to get pregnant, they already have, their tetanus injections set up. Then there's the general OPD, as I mentioned, you have a fever, you go to health services. And then both of the facility workers are responsible, as I said, for pregnancy registration and also for the MCH services, which is antenatal care, delivery, and postnatal care. And then the Directorate for Family Planning, for both the facility and the community worker, they are responsible for family planning. And in addition, the community worker also maintains something called a population register, or, it's called a client register, but actually is basically a population register. So every FWA is responsible for a designated area, which could be like a village, or sections of a village, for example. And what they are responsible for is to identify every household, every couple, right? So every couple with their children are identified as a household. So they could actually be several people. If you have these compound houses where several families live together, then, you can have several families being considered as part of the same kind of household. But they call it a couple register. And what the FWA does is to keep track of all the couples that are in her area, however many children that they've had, if the woman is pregnant, has she had A and C, etc. So basically, if you actually took all the data from all the the FWAs across the country, you then get a population register of people of reproductive age. And that was kind of the goal of this, so that they're able to keep track of pregnancies, births, children, etc. So there are a lot of, services going on, and we have to think of all the different programs that we have to give for all these different groups. So the client register is everyone, right? Everybody of reproductive age, both men and women. And then you have family planning clients, which is both men and women, which is much bigger. Some of them are TT clients, some of them are not, because you can have an adolescent girl who is getting tetanus, but she's, not old enough to be on family planning, for example. Some of them are registered at the public facility, but we also have private facilities in Bangladesh who, where these clients don't, get missed, or they are not, they are not family planning clients. Then we also have women who are pregnant or are on PNC, and you can be on PNC and be a family planning client, for example. And of course, we have the TT clients, which can include pregnant women, those who are registered at the facility, or those who are registered, in the community, which would include the client register. So it's kind of a complex system. You have two different systems, people doing different things. It's a bit complicated. So as we were looking at this and trying to figure out how to design our programs, you have to figure out how, what programs are we even designing, because we have so many different things going on. We have the client register program, which would encompass everyone. And it would be a program that is not repeatable, right? Once you're in it for life. We don't need to close you off and open you up again. Unlike pregnancy, if you have a pregnancy program, you register the person at the end of the pregnancy, you close up the program and that's done. And you can re-register the person again when they get pregnant. And within the pregnancy register, then you have the NCH program, which goes through all the different NCH steps. Then we are considering possibly a TT program, where it is focused on tetanus injections for these adolescent girls and possibly the pregnant women. And that would also not be repeatable because you have just one TT course your life. If you need a booster, we just add you. We never start from scratch, right? Once you've started this TT tetanus injection courses. And then the family planning program also does not need to be repeatable. So we're looking at all these things and realized that we actually had quite a bit of complication here. And so we said, wait, our research program is on maternal and child health. And we need to have this client register in order to just have our entire population in one place. So, something, we're going to give up the family planning. That's not our focus. And also the FWAs who are responsible for family planning generally tend to be much older women who've been with the program for a really long time. And so they are not very tech savvy. And so we didn't want to add more complication. We said, okay, we want them to register pregnancies and keep track of ANCs. That is what our project is for. Let's take out the family planning for now. And we included the TT, but we did it in a different way. So this is how we actually ended up designing this, the set of programs for this intervention. We had a client register, and so when you first meet a pregnant woman, and as I said, this project was strictly for antenatal care and then looking at delivery and postnatal care. So we primarily were registering pregnant women. So everybody gets registered here. And then within the client register, we have the TT stages. We made the TT not a program, but stages within the client register, because everybody potentially will have TT. Everybody actually should have TT because, number one, in adolescence, they immunize you. And then if you get pregnant and you're not immunized, they will they'll provide you with that as well. And then we also have this MCH program. So you first register the person in the client register, and then you enroll them in another program, which is MCH, which is repeatable. Because once a woman has given birth, you close off that program, and next time she gets pregnant again, you create another instance of an enrollment in that program. So within the MCH program, we have a pregnancy registration stage, and then we have the different MCH stages. So this is how we came up with our design. So we had to, and as I said, it's complicated, as you can see. So it's very helpful to write these things out. First of all, I looked at every program, look at all the stages in the program. Are they repeatable or not? And then for every type of health worker, what kind of access do they have to the different stages? The three options were read, write, which is you can edit, you can add information. Read, obviously, you can see information that other people have written, but you cannot add or edit any information that's already there. Or no access at all, where you don't even see the stage, you don't even realize that it exists. And this actually is a relatively new feature within DHIS2. I remember when we kind of understood what we were up against, and I was talking to Markus about it, and we were debating how Markus completely customize it. And he said, hold on, we actually are designing this, we're upgrading the core to have this feature of having user access per stage. And so we actually, this was end of 2017, so we actually delayed our implementation to 2018. So which was when that feature became available in Tracker. And we probably then were the first project that used it. So, just to kind of tell you that some of these things, it's not always there. It actually evolves, DHIS2 and Tracker evolves. So what we then did was you just lay all this out, and I'd encourage you, if you have a complex or even not so complex system, write this out and be very clear what you're doing. So let me focus more on the well, let me start with this one. So with a client register, there's a TT history which anybody can take, right? Any person who first registers a woman can look at a TT card and put all her TT history in it. And this is not a stage that's repeatable, because the first time that we see you and we get all your TT history, that's it, right? Your TT information will only change when you get more TT service. So we don't need to repeat it. If there's new information, we add it as part of the TT service, as in you've now come and you've gotten more, another shot. So we should, add that to your record. So it's only the HAs from the Directorate of Health Services who are responsible for doing vaccination. So they are the only ones who have right access here. And that's something to consider when you're designing your programs, because you should have the rule, unless you're doing, secondary data entry. If you're doing point of care data entry, you should have the rule that the person who does the job is the person who puts the information in, because they are the best people. They are in the best position to know what it is that they did. If they give this information to somebody else to enter it, that's when you have errors coming up. And I discussed that a little bit yesterday. But of course, in some situations, you don't have a choice. You don't have the number of devices or the cost involved in doing point of care. So you have secondary data entry. And so then, that's what you have to do. But if you're doing point of care, we really try to make only the person who's responsible for doing the actual service who does the writing. So if you look at this line, it's only the HA who is able to write, but everybody else is able to read, because everybody is responsible for making sure that the pregnant women do have this TT vaccination. It's really important. You do not want to get tetanus when you're pregnant. So if the FWA goes on a house rounds and meets a woman who has not had TT, she can see it by reading, by having this read access, and she can either contact the HA directly or tell the woman to contact this HA to get her TT vaccination. And then the HA will write in the service that, hey, I've given this woman a TT vaccination. In the NCH program, as I said, everybody in all these 4 cadres of health workers are responsible for registering women, because Bangladesh wants to know who is pregnant. And so they go across the board. Everybody has responsibility for this. So everyone has right access to that stage, because everybody has the capability of registering a woman. All we're doing is asking, when was the date of your last menstrual period? That doesn't need complicated clinical background, and so everybody can put that in. It's not a repeatable stage, because once you're in the MCH program, we are just registering you as pregnant once. If you get pregnant again, it's another instance of the whole program again. So within one pregnancy, you will only be registered once. Then we had different stages for those doing those in the field versus those in the facility, because the field workers are not as technically skilled, right? So the information that we want them to collect is not so much, is very minimal. And so we then decided to have different stages for the health workers versus the for the community health workers versus the facility health workers. Now, somebody could say, wait, why don't you just use the same stage and just hide the data elements that are there, right? Sometimes, so one of the reasons why we did not do that is for the facility workers, we had clinical decision support, which required a lot of program rules and a lot of interaction. And some of those program rules did not work on Android. Our facility workers were using a Chromebook, so we're using web access, and the community health workers were using Android. And so we were not sure how Android would behave with some of the rules that we had for the antenatal care. So then to make it, to not have a problem at all, we had a different stage for our Android users and a different stage for our web users. So that is a possibility to do, of something to do if your Android users and your web users are not doing the exact same thing. You could then have the option of separating out, giving each type of user their own stage. So for the field antenatal care, we did not give access to the health assistants because they are just responsible for vaccination. This is the FWA who, records the antenatal visits that a woman has already done. And we decided not to give any access to the facility workers because, they have their own ANC. They don't need to look at this person's ANC. For delivery, if a community health worker is involved in delivery, the FWA will write it, and the facility workers will have access to read it so that they know that a woman has delivered. For ANC1, we have your first ANC visit is really involved. We get all the history about you, what your previous pregnancies have been. Do you have a history of asthma, of chronic hypertension, diabetes? What is your family history, etc. So it's a lot of data points and a very specific way of getting that information. And then for subsequent ANC visits, is really simple. You come, we check your temperature, we check your blood pressure, we give you medication. That's it. There's no history because that history is done. So we then have a first ANC stage, which is different from a subsequent ANC stage. So that's also something to consider, right? Even if it's the same service, but if depending on what the service is, if it's significantly different from one type of visit to another, you could consider, separating them into different stages and giving different access if you need to. And then we also have a facility delivery stage. So the ANC first stage was not repeatable. This is repeatable because, with every subsequent ANC, we use that. This is not repeatable. We didn't give any access to the community health workers for the facility ones because this is clinical sensitive information. It could include information that I have HIV and therefore I'll be treated, differently. And then, for the facility workers, then they all have right access. So it actually gets even more complicated. I did give you a warning that this was a complicated setup. This is a research study which has intervention and control. Each of the four health workers that we've seen, we divided them into intervention and control. So half of each of the four workers, half of them were intervention and half of them were control. And they had different ways of accessing the system. So one of the big things that we wanted to look at in our research study was to see if continuity of care made a difference, because the setting in Bangladesh just had paper registers. They didn't have common use across the two directorates. They didn't have any shared data about the pregnant woman that they were both taking care of. And there was no shared data between the community health workers and the facility workers either. Meanwhile, they are all seeing the same woman. So we wanted to see if there will be an improvement in quality of care if a user could see, if all the different users seeing the same woman could see, the information or the service that had been given by different, people to that woman. Or if it doesn't make a difference, right? So in a research setting, what you then do for the intervention is you make your intervention users see all the data that anybody has entered so that you know all the services that the woman has received, whether you gave the service or not. And then the comparison, which is the control, is to see for the user to only see the data that they have entered, which was the system, which is the paper system, right? If you're doing paper, is only the information that you write that you see. You're not going to see someone else's register. So even though we went to electronic, we tried to replicate the paper situation by having the control users only see the data that they've entered. So then if you redesign this, this data access, if I put all the control people together, right, the control community workers, they, number one, didn't have access to any of the facility stages, right? All the committee workers didn't have any access to any of the facility stages at all, because this is sensitive clinical information, right? And then we had a stage that we created where we auto-generate an ANC summary, which is information about what has happened in the facility. For example, we wanted the intervention committee workers to know if a woman has gone for ANC or has not gone for ANC, so they can actually do something, and they could see, the kind of the continuity of care, for this woman. But we also didn't want to give them direct access to the actual ANC stage, because that actual ANC stage has clinical information from the facility worker, which includes things like, when they're taking your history, do you have HIV, for example? We don't need, or some other sensitive information that she might not want the community health worker to know. So what we did then was we created this summary stage where we took out relevant information from these stages. So for example, the woman has gone for ANC, she went on this date, and these are the risk factors that have been found. Kim, you raised your hand?
Oh, just giving you a time warning, and my mind is being blown. This is
okay. So this is the last slide, actually. So I just need to explain the rest of it. Yeah, so we'll make time. Good. So then the control will have no access to this stage at all, right? Because we don't want to give them continuity care. The intervention committee workers will now have read access, because it's an auto-generated, stage. All the information is auto-generated. So if you remember, if you have auto-generated stages or like data points, they usually are not editable anyway. And we don't want them to edit. We're just giving you information about the woman, what has happened to her when she was when she went to the facility. So now we look at the intervention facility workers versus the control facility workers. So if you have ANC control, we now gave the control users their own ANC stage, and we gave the intervention users their own ANC stage, so that the control users will only enter data into the ANC control, and they can, write in it. But the intervention workers will be able to read that information. They have access to read it, so that if a woman goes to another clinic, which is control, the intervention will see what has happened there. But when we look at the ANC1 intervention, the control have no access. So again, we are replicating the paper system where the facility worker only sees the information that she writes. She's not going to see information entered anywhere else. But the intervention worker can see both the controls information as well as the interventions information. So she can read. Of course, she shouldn't edit someone else's data, so she can read that. It's a similar thing for the subsequent ANC stage. And then for the auto-generated, there was no need to give the facility workers access, because this is the summary of what has happened in the facility. So, it's the same information. They don't need to get it. It would just be more stages with confusion. So this is kind of the very complicated situation in Bangladesh. It had to be this way because it was a research program, and we had 4 cadres of health workers, and we had to do intervention versus control. So it's like 8 different permutations. And then you also have your ANC1 versus ANC2 stages, which are different. So this is the end. I will, I guess maybe I could leave this on.